Okay, Dr. Lynn, I think you're on. You're
All
good.
right, thank you
Do
very
it.
much.
Yep.
I welcome you all. We will start our meeting, but I don't think we have a quorum yet, so we won't be able to do the consent agenda. Because I miscounted when I realized there were a couple of people that like Mr. Charlie twice. He's showing up on my screen, can't vote. But we'll still move ahead because we have a fairly, I think, busy agenda today. So we'll hold off on the approval of the agenda and the minutes, and we'll move on to the Skokie Health and Human Services presentation. Do we have everyone present here, Mike, who's going to be doing that? I see Brian, and I don't see Officer Blue. I can't hear you, Mike.
Sorry about that. I'm working off of two different screens because I'm at home and I got to start I got to also start the Zoom at work, and it's complicated. But so I want to introduce Brian McHugh to everybody. When I first got to the village in November of 2020, Brian was working for the Health and Human Services Division as a social worker. And in November of the spring or May of 2021, we started this co-responder pilot program where Brian McHugh and our other social worker, Iris Barrios, and the police department would respond to crisis calls for a month. And after the pilot program was done in May, we decided to start up a permanent co-responder program, which pairs a social worker or a human services professional with a CIT trained police officer to respond to crisis calls. And Brian's been doing that full time since November 1st, 2021. We just had our 1-year anniversary. And it's been a very, very, very successful program, and Brian does a great job. So what I'd like to do is pass it over to Brian so I don't steal his presentation and say too much. So Brian, if you can unmute your mic and introduce yourself again and let people know about the program. Thanks.
Thanks, Mike. Good evening, everybody. Nice to see you all. My name is Brian McHugh. I'm a social worker at the Village of Skokie. I've been with the village for just over 9 years. Unfortunately, my partner, Officer Kimberly Blue, is unable to make tonight's meeting, so I'm going to do this solo. I'll do my best to provide you the best overall view of the co-responder program. So like Mike said, the co-responder program stemmed out of the epidemic that was going on with COVID. And, Mike Charlie had a significant role in the development of the co-responder program. Edie Sue Sucker, trustee, put forth this idea, gave Mike the responsibility of doing a lot of research into the data that was going out there with other police departments that might be doing something similar to this. Our program is a little bit different in the sense that a social worker and a police officer are working together, responding out to the community needs. Whereas other police departments were mostly doing follow-ups. So we're out there live in the community in the moment when there is a mental health crisis or a domestic violence situation going on. Who the co-responder program, who we are, is it's the pairing of a social worker with a police officer. And I apologize. Sometimes my camera goes off and on, so I'll try to pay attention to that. It pairs a social worker with a crisis intervention trained police officer who is Kimberly Blue. Kim Blue has been on the police force for over 10 years. We have a partnership. It's a partnership with the village and the police department coming together to formulate this program. We also have close working relations with the various departments in the village, such as fire department, health and human services, the building department, streets. I'm a Chicago guy, so I always refer to it as streets and sanitations, but it's public works department. And we get a lot of referrals from the guys out in the community who are coming across situations and they'll refer to us. What our goal is to promote these services to people who are in crisis and to provide trust and service within the community to Skokie residents. To date, I think the program's been, doing a fairly good job. Our goal, like I said, is to develop that connection to the Skokie residents, provide this service. The type of calls that we go out to are a lot of mental health. People are experiencing a crisis. We respond out to the homeless community that's here, the domestic violence, seniors, family situations, whether it's a parent issue, sibling issues, but we pretty much cover under the umbrella of non-criminal offenses. We have great connections and working connections to the Skokie's rich when it comes to resources. With all the agencies that are here within the village, we have a working relationship with places in mental health like Turning Point, Metropolitan Family Services, the domestic violence agencies such as the YWCA, Niles Township. The work that they do over there is incredible. We have a great relationship with them. How calls are given to us is that they're broken down in 3 different ways. We respond, we listen, we drive around, we listen to the radio, we respond out. Officers who are out on scene will call us out. The Detective Sergeant, Mark Cicchetti, oversees the program here at the police department. He'll assign cases to us for follow-up. We'll get people that call us up and who've heard about the program and reach out to us. Currently, to date, we get about 90 to 100 calls per month or cases assigned to us. As of now, since of November 1st to this date, we're probably over 900 calls, 900 touches of service within the village. Our truck that we utilize is an unmarked vehicle. We don't come with bells and whistles. We're very discreet, very stealth-like. So we're providing that, trust where people feel fear of that stigma of mental health, or the police are in front of my house and all the neighbors come out. So we provide that type of stealth-like service, if you will. We also, in our vehicle, we drive around with food, blankets, other materials that we come across we may be needed for providing that service. I like doing this in person. It's hard to focus in on a screen. So that's pretty much our overview of our program. I work better in a conversation. So if anybody has any questions, feel free to ask.
If people have questions, I would like you, if possible, to use electronic hand on the reaction so I could see you, because everyone's dark right now, except for a few. Are there any?
Add just a few things?
Sure.
So the program was born out of, there were other similar programs around the country, but there weren't a lot of similar programs around the country. So this is actually somewhat innovative and somewhat new to policing. And some of the underlying goals of the program are things like reducing recidivism, de-escalating situations instead of sending a uniformed police officer out. Brian, who's trained, as well as all the police officers in de-escalation, do a really good job with that. What they do really well also, this team, is that they're excellent at identifying and triaging the crisis situations and getting people the help that they need, whether it be, like I said, resolving the initial crisis or some type of longer term case management. The luxury of having Brian and Officer Blue is they can follow up with these individuals, the next day, a week later, a month later. So whereas typically police officers don't necessarily have that flexibility or bandwidth. So not only do they get dispatched out the calls through dispatch, but they get assigned calls where police officers may have gone out and identified that they need that additional case management. So this team has been a huge success and adds a ton of value to the village. And I think that it's somewhat innovative, like I said. And, I think that I've been very happy with the program, and I think that the village has to date. So I do want to thank Brian for everything he's doing, and Officer Blue. I think they're doing a great job. Thanks.
Thanks, Mike. Any other questions? I saw a hand, Heidi, then it went down. I don't.
That was me. I didn't want to gum up the explanation that Mike was giving. Thank you. Brian, thank you for the work that you and your partner are doing, and Mike for helping make this happen. We've talked about this in the Board of Health. I'm a librarian. This is the kind of thing that sometimes public libraries have had a social worker in, and that's really not the acute, it's the chronic, sort of the long-term care. So one, I hope that, you'll remember those partners too, but my heart is very full. I'm very grateful. I'm sorry, I have a very excited dog beside me. I'm so grateful to you and your partner for the work that you're doing in the village. And Mike, I really hope that we can find a way to broadcast more widely the success that this model has had in Skokie. This is so incredibly important, and this approach that is that here to help approach and the meeting people where they're at approach is just so critical, and I'm so thankful. Thank you very much for the work that you and your partner do every day, and Mike for helping make this happen.
With the library, with Thelma and Jackie, and the work that you guys do over there, we wonderful organization, top notch, honestly. Thelma and Jackie are amazing. We also work with Rachel and Laurel as well, with the younger people there. And they can call us and we can go over there and talk to some people there, provide the services, linkage, whatever it may be. But the library is definitely a great relation that we have.
That is wonderful. I'm not at Skokie Public, but really I would like to help spread the word even among public libraries, the American Library Association, whatever, because what you're doing and those partnerships that you have, those impact people on the ground every day. And that's also what libraries try to do, right?
Exactly.
So, but you're saving lives. So thank you.
Appreciate that.
Thanks, Heidi, for your question. I saw Jennifer with a hand. Now it's down.
Yeah, I was only going to point out the question Pat put into the comment section. It says, how do you get your funding? And then, but
I can't.
Mike responded.
So anyone who's interested, please read the comment section. Mike explained how the funding goes. Sybil, I see your hand up.
Yeah, hi, I'm very glad to hear about the program, and I'm so glad that I live in Skokie that has such an innovative way of trying to help the community. That's amazing. So I have a question because it's only the two of you right now. And if there is an unscheduled need and the police call you, in general, what's your response time? And because this can't be happening 7 days a week, right?
No, we operate Monday through Friday from 10 to 6. But we're flexible in the sense that if we need to come in early or stay late, we're also available to be called out on the weekends. I mean, I live in Niles, so I'm not very far away. So there
Wow.
has been times where police have called me, done work over the phone with them, or have come in as well on a time needed basis for on the weekends.
So Mike,
Go ahead, Sybil.
I was just wondering if there was any plans to expand the program given its success.
So two things, just to expand upon the first question and then on to the second one, is that the Skokie Health Department has almost every one of their police officers is like crisis intervention team trained, which is a huge benefit. So although they may not respond to calls exactly how Brian and Officer Blue do, and or have that case management component just because of bandwidth, we have a lot of highly trained officers. The second part of that is, yes, we're discussing that right now. We're collecting data right now, and we've taken a look at it. I guess at this point, I can say is we've discussed it over the last couple weeks, but there's been no decision yet on when that'll happen. But I think at some point it will happen.
Okay, thank you.
Well, now that I'm starting to warm up and I'm getting used to the screen and speaking to a screen as opposed to in person, which I much prefer to do. One of the beauties of the program is that, Mike said a lot of Skokie police officers are CIT trained. Their goal before COVID hit was to get 100% trained, but COVID hit and that put things on the back burner, or slow things down, I should say. But one of the uniqueness of this program is that Officer Blue and I are able to spend time with people in the moment. And that's the crucial part of this, is that when you're trying to create relationship and build trust, is having that ability to stay and be present in the moment with someone when they are experiencing a crisis. When the police are called out, there's other things going on, and they get jammed up and they can't spend the time that we can spend with the person, where it could be 30 minutes, it could be 3 hours. I mean, we've been on calls that we spend 3 hours with the person to get them to move into a better and safer place, because our end of our goal is to make sure that that person is safe at the end of the day. And however we can make that happen and assist with that, that's our goal, is to leave that person with the resources, and more importantly, leave them feeling that they were heard, respected, and that they're safe. So that's one of the things that we're able to do. That's the uniqueness, I guess you could say, in this program. Other places, are using tablets. And I don't see how you can be successful or effective having someone who's in the middle of a crisis, who could be hearing voices or other experiencing other symptoms, looking at a screen and talking to something that's not real, something that's not with them. So I think that's one of the strengths of this program, is that it allows Blue and I to be there and to spend that needed time.
Very good. I saw Bill, your hands up.
Yeah, thank you. Yeah, thanks, Brian, and for Officer Blue, the work that you do. One thing in the healthcare community is the concept of trauma-informed care. How is that incorporated into the work that you do?
So I hope you can hear me, Bill, is that a lot of the work that we come across, a lot of situations are trauma based. And when we utilize that approach, everything is, we use a trauma-based approach, understanding like where the person's at and moving with them in the moment. We're not there rushing around. We're not, it's not a judgmental position. We're, you know, non-judgmental. It's a softer approach. We're not clinicians. We're not there to try to do therapy or rehash up, you know, past traumas, but we're aware of the situation when we're assessing it. We're listening for the trauma when we're there. And that helps us make that better assessment into connecting them to services.
Well, thank you. Are any more questions? I don't see any. I too want to congratulate you and Officer Blue. This is really, I don't know, Brian, if you know, I'm a physician too, but this is something which is really needed. And I'm very happy and proud to know that Skokie is, I think, at the forefront.
Yeah.
And I know how difficult it is. And I know that I'll be curious, you know, Mike, of the study, because it seems to me that a lot of difficult moments occur at hours not between, you know, 8 and 6 or 9 and 6. And so I think we need to really make a effort to expand the program if possible. And but thank you again for all that you do. And you're more than welcome to stay on if you find this entertaining.
I think Brian, I gave Brian an out. I said, Brian, I'll put you first so you can, he's at the end of a long shift. And I don't want to pay him overtime.
Yeah, and well,
I'm just kidding. I don't like it.
no one's on the Zoom that you know, it will appear to you that needing your services. So we'll try to behave ourselves.
Good.
We have a quorum. So what I'd like to do is I'd like to go back to the consent agenda. And initially I'd like to just, and again, we'll use the way that it's been done in the past. You know, we'll call for approval of the agenda. If I don't hear any, I will accept them as approved. If I hear any concerns, I will accept it as approved. Anyone? Sybil, your hand's up. You're muted.
We're going to move the onboarding subcommittee to the March meeting. So I just want to say we could take that off this evening.
Okay, very good.
Thank you.
Thank you. Anyone else? Any concerns? Okay, and now I'd like to call for the approval of the minutes from the last month's meeting. Any additions, corrections, deletions, punctuations, abbreviations? Not hearing any, then I will accept it as approved. And so now we can move back onto the agenda. And we have another guest who is well known to most of us. And I welcome Jen. You are now have a new title. Would you like to tell everyone about it?
Hello, everybody. So I was promoted from as part of the team to the community health supervisor. As most of you know, Sue Riesberg, and she retired after over 3 decades with the department, a well-deserved retirement, and we still stay in touch. But I'm very happy to have been promoted and accepted as a part of leadership with the department.
Well, I will give you an official congratulations, and I am very happy that you're in this role, and I'm sure everyone who gets to know you, if they don't already know you, will agree with me. We asked Jen to come to talk about the Medical Reserve Corps updates, because we're trying really to get this back functioning. The Corps has spent a tremendous amount of effort over the last 3 years in dealing with the pandemic on multiple levels. Many of us were very involved with the vaccination programs, and I am eternally grateful to everyone who has provided their assistance, because this was a monumental effort considering the volumes of people that we took care of. But there's more happening, and I'll let Jen tell you about it.
Okay, I prepared just a very short slide presentation, so I'm going to share my screen if possible. And is everybody able to see my screen?
If you go into the presentation mode, it'll be better. Oh, there it is. Very good.
Okay, wonderful. There we go. So this is Skokie Medical Reserves, as you know, was developed in response to 9/11. They realized that the magnitude of disasters and what was needed from volunteer units far superseded what was available from first responders. It needed to be a hand-in-hand effort from first responders as well as the community. So to get the community more involved in an official capacity, they developed the Skokie Medical Reserves, and that was nationwide. So our Skokie Medical Reserves, most of you know Claudia Braden developed our Reserve Corps. She did an amazing job, and I was part of that Reserve Corps prior to joining the health department as an employee. So our group efforts have done mass vaccination clinics. Throughout COVID, we've had an influx of hundreds of volunteers to help. And many of you who assisted at the clinics regularly got to see everybody in action and how well we worked together as a team. Of course, there's always learning moments, and we're always looking to improve or learn from different experiences and suggestions. So as we are rebuilding after COVID, and trying to find out who would like to remain involved in the MRC after the COVID response, who's available to be part of the MRC after the COVID response, because everybody's availability changed. So we have filtered through all of the applications. We currently have 200 confirmed volunteers. Now what we did was expand it. And originally it was only medical volunteers that was part of the Medical Reserve Corps. What we found was we also needed non-medical volunteers to assist in other capacities. So we have opened up our Reserve Corps to have a medical and non-medical portion. So far, out of those who have confirmed that they would like to continue on with our efforts as a assigned up volunteer, we have one mental health professional. So our goal is to expand that and recruit more mental health professionals. We had quite a few who responded for July 4th, but decided that they only wanted to do that one incident. They did not want to be part of the regular group. So we're expanding our efforts to recruit mental health. If you know anybody who might want to join the Medical Reserve Corps and who is a mental health professional, please have them contact either myself or Rachel Blue. We have 28 individuals that are interested but have not yet applied. They are waiting for personal reasons or professional reasons, but they are on our radar and we keep them informed of the things that we're doing. And of those 28, we have 2 clinical social workers that are also interested in joining. Better Impact is a new volunteer management program that we are using. We are transitioning from Illinois Helps to Better Impact. We're in the process of building it. What we found, especially in the July 4th and throughout COVID response, was it was very difficult to run reports or get contact information for specific volunteer types. So this program will help us better understand who is within our program, what certifications that they have, what their availability is, and what trainings they've had. Let's see. Upcoming events. So later, either tomorrow or next week, we are sending out an email to our volunteers We have CPR training coming up in late March. We will offer both a heart saver for anyone who's not in active medical role, and we also have BLS. The way that CPR has transitioned now, instead of doing it all in person, half of it will be online, and then the last portion, the skills portion, will be in person. But that is something that we are providing for our medical volunteers and, well, our Medical Reserve Corps. In sometime in May or June, we are going to have the American Red Cross come out and do a presentation and include emergency sheltering presentation, just to explain what their capacity is, what their capabilities are, how do they help each jurisdiction, and in that, where can our Medical Reserve Corps integrate our efforts with them? We are also happy to present that we're going to be starting in July, we're going to have an annual MRC appreciation event. Don't believe that's been done before, so I'm excited to have our first one in July. I am inviting everybody who assisted during the COVID clinics and throughout the last few years, just to say a huge thank you. As Dr. Edlin said, we wouldn't have been able to do it without our Reserve Corps. And so we want to keep everyone involved and show our appreciation for it. And then finally, we are doing Stop the Bleed. Now, this is something that has been done previously in our medical reserves. Rachel and I have just completed our certification to be able to train others. So our goal is to train all of the school nurses in our jurisdiction. That's 5 different districts, as well as 6 private schools. And then we would like to train our Medical Reserve volunteers, get them certified as trainers, and send them out to the schools to train the faculty and staff at each of our districts. So this will help. We want our Reserve Corps to get more involved throughout the year, and also continue our mass vaccination clinics in the fall. So if we can engage and get our Reserve Corps in the community and out meeting people and training people, that's one of our goals. So we also, as part of the Reserve Corps, have quarterly call down drills. And this is to keep everyone engaged. This is to keep everyone on their toes, and also meets one of our deliverables. So everything through the Medical Reserve Corps is funded by grants. The lovely world of grants is something that I'm learning. And so this is one of our deliverables for that. And it also helps to keep us integrated. And we're hoping that it keeps everyone engaged as well. So call down drills can be done through email, text message, or a phone call when we get better impact set up. We may rotate the outreach so that 1 quarter will be an email, 1 quarter will be a text message, 1 quarter will be a phone call. And then there's a response time of usually 2 hours that's required to be able to count that as an effective drill. And that is it. Are there any questions?
I don't see anyone's electronic hand or, oh, there, Sybil, I see your hand.
Hi, Jen.
Hi.
Hi. I just have a question on the training requirements for the MRC. And are there, since you have so many people that may be coming on board, is there any information on like what the training looks like to get somebody up and running?
Yes, so that is something that we've actually been working with MRC Illinois to understand. Claudia did have an onboarding process and list of trainings that she provided to each new person prior to COVID, right? Those were in-person sessions. I think it was about 6 to 8 weeks, once a week to finish those. With the influx of everybody, we have reached out to MRC Illinois to see what is actually required. They have yet to provide us any information on that. So, and we've also asked other MRC units in the surrounding areas. So what we're doing is building something that people could complete on their own through webinars.
Okay.
Better Impact will allow us to see who's completed those. So we'll have, we'll keep track of it that way, as well as any certifications that people do. So.
Okay, because it's hard to know if you can, sign on without knowing what the time commitment or the expectation would be as far as the training. So,
Sure. So what we are looking at is we want to make it as easy as possible. So
mhm,
again, previously the classes were in person. It required once a week meetings. We're kind of gearing away from that at the moment to webinars that you can do at your own pace, and just say, listen, do this one course within this month, maybe a second course the second month. And then we will have quarterly meetings. So it is required that you attend 2 of the 4 quarterly meetings to stay active.
mhm.
And those are usually at the end of it's like the 3rd or 4th Wednesday. But we're working to get that schedule together and get that out as soon as possible.
Okay. And has the MRC form been updated to include the non-clinical?
So right now we've expanded the medical to include mental health professionals, and then
Okay.
we are developing one for non-medical.
Okay, so if any non-medical people are interested, should they just contact you directly?
Yes, and they can still fill out the form with at least their contact information and
Mhm.
any notes of any other skills that they would like to offer.
Okay, great. Thank you.
You're very welcome.
Hello?
Wonderful, Heidi. Yes, anybody who's interested from tonight, please just send me an email. It's jennifer.davis@skokie.org, and then I can reach out to you tomorrow or next week.
All right. Well, I thank you so much. And I know this was something that was a little bit overdue, but now that we have a time to take a breath, and literally and figuratively, we thought that this would be something important for the Board of Health members to know. And I certainly hope that we will get a nice response. The support is very needed, and really it's a very gratifying opportunity.
I gotta say, it was wonderful to see Dr. Werner and Dr. Lynn. I would say at least at 99% of all of our clinics, and Pat Urbanis, the 3 of you, was wonderful to work with. So thank you.
Well, it was my honor. So there's things in the chat. I'm not really paying attention. Oh, okay, very good. It's a little hard for me to look for hands and go, oh, there, Bill, I see your hand is up.
Yeah, Jen, great to see you tonight. And the experience that we had, a great way to meet your neighbors, to meet the other professionals in the community. And I would highly recommend that any member of the Board of Health who would like to volunteer, it is just a very gratifying opportunity.
Thank you, Bill. It's wonderful to see you. Looks like you're doing well. Thank you all for having me here tonight.
Well, again, thank you very much. And again, thank you for all that you're doing for the health department. I know that we all have our we're grateful to Mike to keep it going, because we had this rash of retirements that all happened simultaneously virtually. So now it's a new generation taking over, right?
3 different people with over 30 years of experience each. That was a whirlwind right there.
All right. Well, we'll move on with the agenda. At this time, we were going to have the 3-minute introductions. However, I only see one of the 3 volunteers here. So I'm going to ask Pat to take the center stage. You're on mute, Pat.
Okay, ready?
Thank you. Yes.
I introduce myself as Patricia Urbanus. I am a nurse trained at St. Francis Hospital in Evanston. Worked there in the OR for a couple of years. Then decided to branch out. I have a master's degree in maternity nursing. I went to Columbia University PNS to get that degree. I worked in the health department in New York, Harlem Hospital, Sloan Hospital, for a limited time. And then I came back to Chicago. When I did that, I started working at the University of Illinois School of Nursing. And I should put this better, sorry. At the School of Nursing, and we started the nurse midwifery program there with Dr. Lillian Runnerstrom. I worked there for about 8 years. And when I had my children, I moved to Planned Parenthood. And I worked there first part-time, and then I stayed full-time for 20 years. So there's not a story I haven't heard, just the faces have changed. And then after I also worked at infant welfare and some of the Board of Health stations in Chicago. And then after Planned Parenthood, yeah, I worked part-time at infant welfare for a limited couple of years. And then I decided to get involved with the MRC. And actually, I think I was in the second class of the MRC. So I don't know how many years ago that was, but I'm pleased to be involved with that and also on the Board of Health. So that's me in a nutshell. I have a husband who's also retired. He's a writer, PhD. I have 2 daughters. One daughter teaches history at Stevenson, and the other daughter works for the Department of Natural Resources in Springfield. And we live over here 2 doors down from Bill.
Well, that's very good. Are there any questions for Patricia? Well, again, I thank you for volunteering. I'll let the rest of the people who haven't, I think we're gonna have to work this out, because now we have 2 absentees who were part of the the court today. So I guess we're gonna have to push them to next month, hopefully. And so we'll need a third person to volunteer before the end of the evening. We don't have to decide right now. Rohit, I see a hand up.
Like you mentioned, 2 of the people who volunteered to speak for themselves and introduce themselves to the board, they're not there. Can I just speak today, or is it too late?
No, it's not.
Thank you. Thank you. My name is Rohit Pandya. I tell people to call me Ro, so it's easier for people to remember my name. I was born in Mumbai, India in 1952. My parents, especially my father, was in a government of state of Maharashtra. That was the state of where the Mumbai is. But in 1960, they made another state, and my father decided to move to new state, which was Gujarat. So I was raised up to 8 years in Mumbai. Then we moved to a city called Ahmedabad, and that's where I studied my pharmacy. It was the LM Pharmacy. That was the name of the school. After graduating in 1974, American government were inviting all the medical people, engineers, nurses. Being a pharmacist, we were able to get the immigration visa within like a couple of months. And I came to United States in 1976, month of March. Luckily, I was able to get the job within a month in a small pharmacy in Newark, New Jersey. Stayed with him for about 6 months. Boss not being that great, I figure, let me try and do some other pharmacy. And luckily, the house that I stayed across the kitty corner, there was another pharmacy. And I went to him, I applied, and that afternoon he called and he said, come on over, I need a experienced technician. He asked me a few questions. He hired me and I stayed there till 1980. The reason I'm saying up to 1980, because in year of end of 78 and 79, Illinois State also needed a lot of pharmacists. So a lot of my friends were here. So they said, instead of staying in New Jersey, why don't you come on over to Illinois? So I moved after my license to Illinois in 1981. Incidentally, it was the day Ronald Reagan was inaugurated. I was in a train from Newark to Chicago. Those things generally you don't remember when you have to tell the story about your life. Those dates come into your mind. I came to Chicago. Pharmacist jobs were very easy to get. Luckily, one of my friends needed pharmacy, so he introduced me to someone. I started working there. I worked for about 2.5 months, and the Walgreens Corporation needed pharmacists, so I applied on April 6th. I joined them on April 11th, 1981, and I retired from Walgreens in October of 2020. I live in Skokie. I've been a board member, I believe, since 2007 or 8. I'm not sure exactly what year. I have 2 children. One, my son is a podiatrist. He's practicing in Downers Grove. My daughter lives in Lamont, and she has a business and marketing degree. I recently became a grandfather again with my granddaughter. She was born on January 1st of 2023. She was the first baby in Chicagoland area. And my daughter and my son-in-law, and they were all on the news on Channel 7, 5, 2, and in the Chicago Tribune. What else can I say? I live in Skokie, and I'm very happy to be a board member of the health department.
Thank you, and thank you for your willingness to jump in at a moment's notice, and I'm very appreciative.
My pleasure.
And any questions for Rohit? Ro, but I can remember Rohit, so I'll stay there.
Perfectly all right.
All right, so thank you again. So we still need to move those other individuals to next month, Mike. And I will. I want to do my report, and so I decided, and I'm going to try to be as brief as possible, because I know that I'm involved in 3 other major COVID enterprises. When I'm not involved with the Board of Health, I'm providing educational support for some other projects. And we know that the national emergency will end May 11th, 2023, according to President Biden. But what does that really mean? And I'll go to the next slide, thanks. Now, most of what I'm providing you, I've taken from a newsletter that I received called Your Local Epidemiologist, which I read religiously because it's so well done. This is something which everyone who's concerned nationally, because we know this is complex. And the first thing I learned was there isn't one national emergency declaration surrounding COVID-19. There are 5. And I listed these 5. Example, the emergency use authorization for medications and for the vaccines that we've used in the past, and then we now have a new booster under the EUA. This all comes from the FDA. We also have a Stafford Act, which created FEMA. And for those of you that may or may not know, FEMA was responsible for running the mass vaccination clinic at the United Center in Chicago. I went there to visit it because I was part of the planning committee for it. And to my surprise, it was the United States Army who was there, drawing vaccines and administering the vaccinations. And now we have the public health emergency. And, and that is something I'm going to delve into a little bit more about Medicaid extended coverage. And that's under the public health emergency because they waived the fact that people have to renew their Medicaid on a regular basis. So people were continuing to have their coverage. And this expires in May. The quote unquote national emergency expires in May. And the PrEP Act, and many of you may not know what have heard it called the PrEP Act, but I certainly am aware of it. And I'm sure many other licensed professionals. And this was the act to create immunity from liability for the COVID-19 vaccinators. And we don't know when that will expire because it's now currently under legal review. So the federal government's lawyers are trying to figure out what they should or could do with this situation. Next slide, please. So here's some speculation. At this time, we don't know for sure what's happening, and each category may be under a different timetable. And so I'm telling you this because you're going to hear more questions. And one of the big hot button issues has to do with vaccines. Now, the EUA is not ending in May. It's not on that schedule. And this means that COVID-19 vaccines will be available, but available is different from accessible. So vaccines will be covered by the government until the stockpile, and this is the large, enormous amount of vaccine which U.S. government, purchased, from various pharmaceutical companies, quote unquote, dries up. After this will occur, will hopefully be by the fall of this year, and a new formula booster is in the works. And how that is going to be paid for or funded, right now it's speculation that private insurance will cover this through employer plans. Public insurance, Medicaid and Medicare will cover it. And that should take care of about 92% of the Americans who have health coverage. Now, the concern for many of us, and it could impact Skokie, is what will happen to the uninsured. And it's not clear. When I say we've been told, we hear this from various governmental agencies, but no one knows for sure that no one will be left behind. So that's a TBD, on the pegboard. So what does this mean for the public? And I really feel this is something we should be urging right now because we're woefully under-vaccinated. And if you look at the, and I won't get into it, I talked about last month too, that the updated bivalent booster, people should be getting it as soon as possible if they haven't already had it. And I know there's some speculation that in the end of February, it's actually going to be the 24th of February, the ACIP will be meeting again. Right now, the recommendation that came out from a week ago or so was that we will have a new booster formulation for the fall, with the hopes that we can go on an annualized basis. But we do have a significant number of high-risk individuals, people over the age of 50, but most specifically over the age of 65, children that are young, and then the whole group of spectrum of individuals who have medical comorbidities and immunocompromised states. And so there's been a lot of questions whether or not we should have another vaccine at 6 months. So I'm going to move on to the next bucket, the public health emergency, which ends in May. What about antigen testing? Well, the supply is going to be impacted, but not necessarily because of PHE. It's something else. This is the big issue with the congressional budget. We already know these tests are commercialized, so people can buy them anytime they want. The U.S. bought a stockpile of antigen tests for the United States Postal Service program And I don't know if any of you have done so, but it was really kind of remarkable how easy it was to get a significant number of antigen tests. And it was running through this winter, and there's still a stockpile for coming months, but it's very unclear when they will run out of it. Public health emergency requires health insurers to reimburse for up to 8 antigen tests per person per month. And that's the current standard. After May, it'll be up to the insurers to choose whether or not they reimburse for these tests or not. And so we don't know exactly what that's going to have. It's important to realize that a good strategy is not to stock up on it now. Reason being is these tests have relatively short expiration dates by the time you receive them. And I know a lot of the manufacturers have extended the expiration dates, and it's a fairly laborious process to go online. The CDC has a site where you can verify if they've been extended, and many of them have been extended. But so probably if people are interested, and of people who are interested in getting more tests, they should probably wait, a month or so and try to pick them closer to May so they'll have a little more life in them. Next slide, please. So this is the healthcare coverage issue, and actually my reason for my presentation started because of this discussion that I had with Mike Charlie and with Sybil Yao. So one of the most impactful tools during the emergency was Medicaid's continuous coverage. In other words, at least in Illinois, but in many states, it works a very similar way. People had to kind of have their eligibility verified, as because people's circumstances change, their income changes, and so this was done on a regular basis. However, during the emergency declaration, that was waived, so people had continuous Medicaid coverage. Now, these checks were removed during the pandemic, but these checks will resume on April 1st. And one of the reasons it'll be April 1st is, again, we originally felt that the public health emergency was the kind of the rules we'll follow, but they passed the omnibus bill in December, and that uncoupled Medicaid from the public health emergency. So this doesn't have to do with the public health emergency ending. It's going to change because of this new omnibus bill. And between 5.3 and 14.2, big number difference. This is quite a spread, because they don't even know how many people will be affected, could lose Medicaid coverage. And this could impact Skokie. And I know that we've had some discussions, and Mike may want to comment on this, but one of the things we're concerned with is that we may have residents that aren't aware of this. And if they haven't updated their contact information with the state, they may not learn about it until they longer have coverage. So this is what we're up against, because again, we don't have a federal plan. It now goes to the state. May I have the next slide, please? So the big issue, and I kind of touched on this, is what is national, what is state, and what is local. And again, the declaration that things will end in May 11 was national. I know the governor agreed to follow the national plan in Illinois, but it could vary in other states. And as I mentioned, that the states are responsible for the Medicaid transition. They're also responsible for wastewater surveillance, which has become the only standard that's fairly reliable now to determine what is the disease burden in our society. Because, and an example, in California, the state budget for COVID-19 funding will be axed by 90%. This means wastewater monitoring in California may be reduced, regardless of a grant from the CDC. But in New York, as an example, it's more protected because the state made a decision on this. So we have yet to find out what's going to happen in Illinois. May I have the next slide, please. So this is just a list of national surveillance strategies, wastewater being one of them, but we're also concerned about a genomic surveillance. And it's understood that the wastewater program will remain now, but genomic surveillance is telling us what variants we're dealing with in the population. So this is valuable information. And again, who's going to be responsible? Basically, it's all about paying for it. Test positivity rates will likely go away because the CDC can't compel labs to report. That's something we've learned. The CDC does not have any authority, but under the emergency, they were compelled by the government to report positive tests. But as we know, very few people, relatively speaking, are going to labs to get their tests done. They're doing the antigen test, so it doesn't get reported at all. So what the CDC is focused on is hospitalization. But we don't know now how often the hospitals will report. And that, again, could be controlled more by the state or local authorities. Similarly, when you look at vaccine uptake, well, right now that's being monitored by the state. And hopefully that will continue. Certainly, all the information that's being put into iCares gets shared with the CDC. Another important thing that we may have taken for granted is that many pharmacies were doing testing, and these tests were sent to commercial labs. And the CDC found that was the best way to determine whether the vaccines are working. And so we don't know how that's going to go. So there's so many questions. What does this mean for the public? It means that we'll have a skeleton monitoring system of COVID-19. So it may be more challenging to know when we are in a new wave to inform our behaviors to get more, it'll become more and more challenging. So it's we will have to wait and see what's coming up. But I thought I'd just go over this with you. And I'll now at this point answer any questions. And good, there aren't any. So I've either dazzled you with, well, I didn't have any data, so I didn't dazzle you with data. So I must have baffled you with BS. But I will now turn this over to our director, Mike Charlie, for his report.
Can you guys hear me now? Okay. So I just want to thank Dr. Lin for his presentation. For the sake of time, I'm going to try to get through mine pretty quick because we still have Sybil to give a presentation after me. It's a busy Board of Health meeting. So here are some updates on COVID-19 data since our last meeting. Cases have been increasing, and again, that case data is case data from what's actually being reported through our labs versus, we really don't know how many cases are being found via antigen tests, and we're just not going to know that. But definitely cases have decreased in Skokie. The Cook County COVID-19 community level is low, which means that the transmission rate in Cook County is actually below 100, and hospitalizations have actually decreased recently. And that's why the community level is low. Our transmission rate here in Skokie is really at its lowest rate since almost a year ago today, back in April, I think, of 2022. And we're at about right around 100 cases per day. If it decreases to below 100, we will be at a substantial level in regards to transmission rate for the first time in a while. Our 7-day moving average cases has decreased from 15 cases to 9.7 cases a day since the last meeting. In addition, the iCare data shows that about 18,814 Skokie residents have actually received their bivalent boosters, which is about 31% of our population, which, Dr. Lin had mentioned that, we need to push and push and push to get people their bivalent boosters. And that is something Jen and I have met about, knowing that as of May 11th, we may stop receiving free vaccines to the Village of Skokie Health and Human Services Department. We will be using our marketing tools to encourage people to get vaccinated either through the village and or through one of our local pharmacies. We're still administering Moderna to all age groups. We've administered about 34,500 doses. And to date, we've had about 23,000 cases of COVID that we're aware of course, through lab testing. This is a chart of the cases since the beginning of the pandemic. And you can see it's very small, but we've seen a decrease recently in the number of cases. This is the community transmission level. We've essentially been at a high level for most of the pandemic, although you can see around the beginning of April 2022 that we were at a lower level. That actually is more of a substantial level. That looks like low, but it was substantial. And we are getting very close back to being at a substantial transmission rate. I wanted to show this slide just for the sake of, go ahead.
You're
Jen.
not sharing your screen.
Yeah, thank you, Jen.
Well, that stinks. Okay, hold on one second. Okay, so this is a chart. You didn't really miss much, but this is the chart of Skokie cases on the 7-day moving average, and you can see a slight decline in cases recently. This is the transmission, community transmission levels, and where I said we had essentially been high for most of the last year, and we're almost have gotten to below 100. We're exactly at 100 right now, right around 100. So only time will tell if we continue to decrease in cases. This is just to kind of show how many, this is what we are able to get eye care data on the number of vaccines administered to Skokie residents. And as you can see to the left here, where it says Skokie Health and Human Services Depart, we've administered more doses to Skokie residents, really over 3 times more than the runner-up, which is a Walgreens store, number 15066, which I'm not really sure which Walgreens that is, but you can kind of see down the line how Skokie residents have gotten vaccine from Evanston Hospital, LaJewel, CVS, Erie, Evanston, Skokie Health Center, and other providers, but far and away, we've administered more doses to Skokie residents than anyone else.
Over what time period was that, Mike?
That's since the beginning,
Okay,
since the end of December 2020. So, or 20, yeah, I think it's 2020. So this is that's an old slide. I'm going to skip it. I didn't update. This was that previous slide was a slide that I had provided last time around. I haven't updated. So, but essentially the state curve in cases is pretty much exactly like Skokie. Some staffing, here's some other updates regarding Health and Human Services Department. So we had posted an open social worker position, and we had 50 plus applicants. About 30 of those applicants were actually qualified. We have reviewed the apps, and we are scheduling our first interview tomorrow, and we'll have another couple interviews next week. And hopefully we can have a new licensed clinical social worker or licensed social worker on staff within the next 4 to 6 weeks. Grant updates, occasionally we have certain grants that we receive year after year. They're the non-competitive grants, right? Like the local health protection grant, our public health emergency preparedness grant. But this new grant, this COVID-19 monkeypox and influenza grant, is a new grant we're receiving. It's another $200,000 that we're getting, and it's just going to help support all the services that we currently provide. The Illinois Secretary of State works with Health and Human Services to schedule rules of the road courses at Village Hall. And I just wanted to mention that there's 4 courses and people can make an appointment through Health and Human Services, or 4 upcoming courses. At this last board meeting on Monday, the village board approved us to move forward with an agreement with Platinum Pest Control Services. The biggest difference with Platinum Pest Control is that in the past, we only utilized a licensed pest control company for about 8-9 months of the year, and then the remaining 3 months we used staff to go out to our properties of 4 units or less to bait for rodents or rats. But lately, because we've seen an increase in rat cases, we thought it best to hire a pest control company to be out weekly for a full calendar year. And I think that's going to help strengthen our rat control program and ensure that we're visiting every property once a week for the remainder of the year. I wanted to talk, I forgot to attach the pictures, but the Village Hall Health and Human Services waiting area. I had some really good pictures to show you too, but I forgot. I was running out of time at the end of the day. But we've upgraded our lobby, and if anyone's interested in seeing it, it's pretty good. We've added all new seating. We've added the front counters being remodeled to enhance security primarily. It's gonna include 2 secure doors and a window from floor to ceiling at the front desk. And we also added a projector and a screen. And during clinic hours, we show informational health videos, and we do show cartoons and other things during our children's clinic to keep the kids busy. We also have some kids tables and puzzles and other things to keep the kids busy. And then I wanted to mention again about our AARP tax program. It's a program that we partner with AARP and promote, and we take appointments through Health and Human Services from February 8th through the middle of April. That program helps. It's free of charge for low income and senior citizens and people with disabilities. And if any individuals or residents are interested in using the program, they can call the health department. I'm going to skip this part because this part of my presentation was to talk a little bit about the impact of the end of the emergency declaration. But I think Dr. Lynn did a really good job in describing the fact that Medicaid, the continuous eligibility is ending, and that people are going to have to reapply for funds, and that SNAP benefits. There was an emergency allotment of a minimum of $95 per household that was added on to people's SNAP benefits. So in response to both of these, we will be posting something in the Skokie News this next Tuesday to communicate to people to make sure they update their addresses with the agencies that run these programs, just to ensure they get the letters in the mail and they don't lose any of their coverage. So I'm going to skip this part too. So everything you see here is what Dr. Lynn presented, but he did a way more thorough job than I would have done. So I appreciate Dr. Lynn, you doing that. Future Board of Health meetings. So the next meeting in March, I actually have on the schedule to have Jen Davis come in and talk to everybody and present on our communicable disease surveillance and control program and our clinics and our screening. So that's something that we can look forward to happening in March. Are there any questions?
If you'd like to see the pictures, I did bring them up real quick. I can share my screen.
Sure, go ahead.
So here is,
Oh, look at that.
there we go.
You want to describe them? I mean, I can describe. Go ahead and describe
Yeah.
them.
So this is the lobby area as you just come down the stairs from the first floor. To the right is our front desk area. These seats are facing our front desk to the health department. As you see, we have kids seats with puzzles and activities that we put out for the kids. And then seats here to also see the projector in the back that we've gotten. We also display information if we have any upcoming events, we'll put that on the projector as well. Let's see. This is our new front desk area. They've added these half walls here. They're going to put a closed door system over here and on the left, so it'll be closed off. And they'll be installing thick protective glass around the area with areas that you can speak and slide papers underneath. But it looks very nice in person, and it actually looks much more welcoming than it did before. This is from the camera view of the waiting area in our front desk area.
That's an amazing panoramic by one Mike Charlie.
It is. And then this is from within the health department outward.
Yeah, it really does look good. I mean, I don't know.
It looks
a
very
lot better
nice.
than it did. It looks a lot better than it did.
It did, yeah, absolutely.
I agree. It does look excellent compared to what it used to be before.
Thanks, Jen.
Sure.
So unless nobody has questions, we can move on to Sybil's I-Plan update. Is that okay? I'm going to start.
Yes, absolutely.
I will start up her presentation, and I promise to share it.
Okay. And the slides really have to be credited to Liz Nelson, who did a great job in helping out with the slides. So this is the roadmap and the timeline for us to work on. And so they're completing the analysis by the end of February. And then we're going to start our meetings in March, and then we'll have our objectives created. And then working all the way through until August, or when we have to present to this, I'm sorry, July is 24th is the steering committee, and the Board of Health will need to meet in August on the 11th to approve the plan so that it can be approved by the village board and then go to the public health department. So working backwards, we can see that it's a really short time frame to get our I-Plan business completed. So the board meeting, we don't generally meet in July and August, but this year we are going to need a meeting in August. So I hope everybody can put that on their calendar, because we will definitely need a quorum to be able to pass the plan along and approve it.
I'm sorry to interrupt. What is the exact date in August? I saw a couple there.
August 11th, I think, is our second Thursday, if I'm not mistaken. The
Okay.
village board is got to get it on the 21st. So there's actually 3 dates in that box. So the steering committee for I-Plan needs to approve to move it to the Board of Health. So that is on the 24th of July, and then the board meets, our board meeting is the 11th of August. And then it goes, and if it's approved, it goes to the board, the village board.
Yeah,
All right.
Dr.
Well-
I would say we have some flexibility in August.
Yeah, I here's my point. Most people, I'm sure, have taken that date off their calendar as a Board of Health meeting, since it doesn't traditionally occur. So I think now is the time to, we have a number of people who aren't present tonight. Rather than just rely on the minutes, can you send something out to them and maybe poll them and find out whether or not we're going to get a quorum? Because for some people, they may already have plans.
Yeah. What I can do
Okay.
is I'll send something out, and then we'll as we get a little bit closer, we'll send out a poll or a doodle, because that meeting really it could be a short meeting, it could be a long meeting, but we'll figure it out. I mean, I'll send something out though for that.
Yeah, I appreciate that. And now August 11th in my calendar is a Friday.
Okay, so it would be, well, I don't know, the 10th then would be the Thursday,
The
right?
10th would be the Thursday, yeah.
Okay, so, but Michael send out some messages and get people's input on the date, but we do have to meet. So I hope we can arrive at an agreeable date.
Excellent.
Okay, so the I-Plan, if you look at the 10 essential public health services, there are, these slides represent the ones that were selected, which was number 1, assess and monitor the population health. And these were some of the data collected from the I-Plan is the information from the assessment, which was the community health status, the community themes, and the local public health system is how we assess this service number 1. Next slide. So number 3 is communicating effectively to inform and educate. And once this I-Plan report is made, then it will be shared with the public. And collective impact will state that for best results, 51% of the people working on each of the initiatives are from the affected group. So that's true to involving the community. So this piece of effectively communicating is going to be huge for our I-Plan. Next slide. Number 4 is strengthen, support, and mobilize community partnerships to improve health. So this will be the community and the coalition comprised of community members, stakeholders, in addressing the 3 priority issues. So this is one aspect that I think I would like to see if our board commissioners can help us, because they're involved in different community efforts, which will definitely be of great help to us in getting community support and input. Next. Number 5 is create a champion and implement policies and plans and laws that impact health. So the Skokie Health Equity Network, which is what we're calling this I-Plan, is using the collective impact so that we will be able to choose the strategies that will make sense for systems to change. Next. Number 7 is equitable access. So the effective system, which is going to come from the collective impact, and in understanding who's marginalized, why they are marginalized, how they are experiencing being marginalized, and choose strategies that target these actions to create policies and practices that will address these inequities. And then this is just a high level update on where we are with the healthcare and the mental access to mental health. So there's one group that's going to be healthcare, and these questions across the row here are kind of the general questions that came out of the November 18th meeting. They're not solidified yet, but it's the general sentiment is looking at primary care providers. How big of a barrier is it to get to medical and other appointments, and then data on insurance coverage. The access to mental health, and the questions are provider ratios of mental health providers to Skokie residents, the data from the emergency room, and what needs are coming through the door, and pulling data from school mental health screeners. And I know that we had the presentation on our from our co-responder program, so that information will be folded into this one as well. Next. And then these are just some provider ratios that we obtained from the databases that Liz has. So broken out by zip code, you can see that the ratios are different for each one of our zip codes, and both mental health providers as well as primary care providers per 100,000 residents. Let's see. And the qualifications are underneath each one of those. I don't think we need to really go into that too much. Next. And then the affordable housing is our third initiative, because affordable housing is the #1 determinant of social determinant of health. So she's looking at rental versus owned housing and the gaps, the single family and multifamily housing, and then rental by geographic area, by foreign born and other demographics. Some of the data that came out of the community survey showed that we had some geographic clustering of foreign born and other populations in Skokie. So that's why that's there. So these, and then she's got, Liz included this percent households by census tract, where 30% of the household income is spent on rent. And you can kind of see what the breakdown is of households that are saying that they're spending 30% of their household income on rent. And this, there's probably, we just wanted to show that as an example of a slide that we were looking at. And the database from that is the City Health Dashboard. So there's 9 databases that are accessible to pull data from. And part of the Collective Impact Initiative is there's a data team that's supporting the work of the 3 teams that are looking at health, mental health, and affordable housing. So it's quite an intricate, complex way that we need to get the data to the group so that they can make the proper decisions. And that's it. Anybody, are there any questions? I don't see anybody. Okay. Thank you all. Oh, the first meetings for each of the groups is going to be in March, and they will be virtual. And Liz is kind of working out a schedule for meetings, because I would like, if anybody has any interest or questions, the meetings will be announced so that, you know, people can attend. And if you have any questions, you can email me directly. I'll put
And
my,
that will be sent out to the entire board, these dates.
yes. And I'll put my email address in the chat.
All right, well, thank you so much, Sybil. I know that, you know, this is a big evolving project, and I appreciate the fact that we really have to adhere to this schedule because of the deadlines. And hopefully we'll work out that date in August to everyone's satisfaction. The last thing on the new items under the old and new business would be, again, this May 11th date, you know, of the suspension of the emergency declarations. And the question is whether we have to, after that point, switch to in-person meetings. You may be aware, and again, I hope everyone was trained and understanding about the Open Meetings Act. You know, when you join the board, that as long as we were under the governor's emergency declaration, we could have virtual meetings. One of the byproducts of the pandemic is that more and more of us are becoming very comfortable now with virtual and hybrid meetings. And to some degree, it's becoming hardwired into our culture. And but there may be a need to go back to in-person meetings. And Mike, you want to bring us up to date if there is anything new, because I know that we've had this discussion and you were going to be checking with the village manager and other leaders.
No, I actually talked to the village manager about this today a little bit, but as far as I'm aware at this point, the Open Meetings Act allows remote meetings if there's a disaster proclamation from the governor, and it's going to end May 11th. So I think we have I think May 11th might be a Thursday or Friday. So our meeting in June will have to be in person. So unless something changes, that's going to be the case. That's my update.
And, it's kind of ironic because the last time we had an open meeting, an in-person meeting, I think was June. And we struggled because we weren't getting quorums. And so we went ahead with the meetings anyways, but some of our commissions actually cancel meetings if there isn't a quorum at that moment.
Yeah,
So it'd be important for us to work out this situation, and members have to understand that there's also importance of attending the meetings. Yes, Mike.
I have just one last thing. I know it's been a longer meeting, but the Board of Health meeting in August, where we have to meet to approve the I-plan, I might recommend or set the seed for maybe what we can do is we can meet and have some sort of meal. Get together and break some bread. Maybe I can get like the lunchroom at Village Hall, and it'll be a public meeting, but we can order some food and we can have a meal and vote on the I-plan and get together and enjoy each other's company.
Well, I know I came from a culture where it was always no eating, no meeting. So that's something I understand. All right, well, thank you. Now we have to open this up to any public comments. You're on mute.
Yeah, give me a second. Let me see if there's any public comment. This is going to take me.
While Mike's doing that, are there any other questions that people have?
Checking. Yeah, I don't see anything. There are no public comments that I can see in the there is no public comments that I see in here. So we're
Okay.
good.
Well, thank you. Thank you all. I'd like to call for a motion to adjourn.
Motion.
Anyone second it?
I second.
Second.
So I will let you all vote by clicking off. And if anyone is left, we'll have an intimate meeting.
Okay, thanks, everybody.
Thank you all.
Thanks,
Good night.
Debra, for your presentation. Jen, you too.
Thank you all.
Good night.
You guys.
Oh, one terminal thing. We need some more volunteers for next month to introduce themselves. So you can just send that to Mike or myself. Thank you.